And let's move on to the next question. So we've got a whole new case coming up, a fresh start if you weren't happy with the last case, and we'll bring 2 minutes on the clock. Shirley's aged 68 years, attends your GP clinic with a 3-month history of generalised itch. It began suddenly and she's unsure of the cause. She has no significant medical history, takes no medications, and has no known allergies. She's no recent travel, doesn't smoke, drink alcohol, or use illicit drugs. Surely you sound a bit boring. To examination, she appears generally well and vital signs are normal. Her BMI is 25. Her skin appears unremarkable, as is the rest of her examination. What are the most likely diagnoses? Write 6 specific differential diagnoses. All right. So I hate these questions where everything looks good, but the patient's coming in complaining of a chronic cause. For these kinds of things, it's often handy to have kind of a backup mnemonic or a way to think through all the different causes for a presentation. And for something like this, a generalized itch, I often just fall back to, well, what's anything that can make you itchy? And really, you can often build your answers around that. And so, certainly, the things that can lead to itch, and in an otherwise seemingly well 68-year-old, the first thing I would always think of is that renal failure. If you've ever worked on a dialysis unit or a renal unit, you'll know that itch or pruritus is an incredibly common presentation. And in particular, they've gone out of their way to specify this is a chronic itch there, 3-month history. It's a long time to be itchy for, and so it's more likely going to be one of those chronic conditions. And pointing away from things like allergy or atopy kind of as an exposure. Tied in with that then, one of the things listed is jaundice and liver disease. I think I'd be more inclined to specify liver disease or hyperbilirubinemia, but they have specified that her skin appears unremarkable. And in my opinion, I would be hesitant to put jaundice if they've kind of specified against that, but it has been seen to be an accepted answer previously, so I'd probably specify liver disease. Diabetes, again, tying into polyneuropathy, things like that, can present with chronic itch of otherwise uncertain cause. And next, of course, is thyroid disease, because let's be honest, thyroid disease can present with just about anything. Tied in with that, and calcium regular hyperparathyroidism can lead to chronic itch. Iron deficiency anemia, this is another one of those weird and wonderful things. I've seen a patient end up with complete paralysis of an arm due to profound iron deficiency. Malignancy, solid tumour malignancy can do that. And so can, and interesting to note, they were happy to accept solid tumour and any appropriate example of solid tumour for a point, and hematological malignancy as a separate response as well. Polycythemia, as chronic itch is a big component to presentations there. Neurological conditions as a kind of catch-all, and they would accept things like Parkinson's disease, as long as you or MS, as long as you're giving some kind of sensible answer in that domain. Psychogenic if everything else seems to be perfectly fine and everything else is within normal parameters, have to consider potential psychogenic causes. And of course, then tying into some of our infectious causes, things like HIV, in particular HIV seroconversion, or hepatitis C, which also ties a little bit into liver disease as well. So I'd be avoiding overcoding and, I'd be trying to diversify my answers, and I'd be having those as probably two separate things, but I wouldn't be using both of those answers in those 6 responses unless I was really caught out. Moving on then, we have another question lined up. We will put 2 minutes on the clock. Well, that's a little bit embarrassing. I forgot to put in how many you're supposed to be choosing. Very sorry, everyone. So for this one, we'd be choosing 5 and highlighting that the key thing there is what initial investigations are appropriate. So from here, there's, and for these types of questions, there's usually more than 5 correct responses. So don't feel like you're getting caught out if you're looking at things and saying, oh, but that's also correct, that's also correct. Just specify 5 that you know for a fact are going to be right. And for these things, trying to tease out the most important things here, what's going to be best bang for buck for your initial investigations is where the big points are at. So of course, for this kind of presentation, you're going to have your liver function tests, your full blood count, your calcium levels, parathyroid, iron studies as we've spoken about, your UNEs tying into that renal feature, and that'll be my first response there, certainly worth 2 marks, and thyroid function tests. Now, and of course, fasting glucose if we're covering diabetes as well. Would you be ordering some of these other tests down the line? Potentially. And this is where, again, highlighting where after the initial investigations, that first little trip to try and see which domain we should be looking into further to try and manage this condition. And so really it's casting that bit of a wide net, considering your differentials and then trying to work out what's going to help narrow down that list and point me in the right direction. Hopefully everyone's happy with that. And of course, coming in almost at the end, guys, hang in there. 2 minutes on the clock. Her results all return normal and her rash quickly vanishes, I should say itch rather, without further intervention. She returns a few months later. As you note, she does not have an advanced care directive. What barriers might prevent a patient from creating an advanced care directive? Please list 3 specific barriers. right, hopefully you guys all did well there. Let's have a look at some of the answers. Now, again, let's cross that one out, and that was H. In this case, we're trying to diversify our responses to try and maximize our marking. And so for this situation, what areas could there be potential barriers? And any sensible response with any of these three domains would be given the point there. So GP barriers, so what comes from us sitting in the chairs? Well, things like the perception patients are unwilling to participate or discuss death and dying, removing the fear of removing hope or damaging relationship, GP fear of challenging patient preferences or potential emotional impact on the patient, GP time constraints, GP lack of training or comfort in performing these things, and of course, the age-old thing, lack of remuneration for the time it takes, which admittedly to do these properly does take a long time, remuneration to actually perform these. Then the other side of the chair, patient barriers. So patients might not be aware they exist at all. They might be reluctant to communicate end-of-life issues. They might even see them as irrelevant to them, or believe that their wishes are already known to friends or family, or there could even be language barriers that's stopping that communication there. Now, external to those two people in those two seats, there can be health system barriers as well. And this can be with the clinic level all the way through to tertiary hospital level. Now, anyone that's filled out these forms knows already there is significant fragmentation between the states around what is contained within these directives, how legally applicable they are, and while there has been a lot of work in recent years to try and consolidate all that down, there's still a lot of work that needs to be done. There can be changes in preferences, so what people have specified in their directives at one point may be different to how things are now, and it can be cumbersome and difficult to actually track down who has copies of what and update them. Things could be poorly documented or using incomplete or inappropriate terminology as well. The catch-all term of not for life support. What does that mean? You need to be very specific and clear in terms of what you do and do not want. That ties into as well lack of clarity, as well as a poor ability to store or access advanced care directives. So is there an appropriate system in place so that these can be recorded and, if need be, retrieved for review? Excellent.